Neonatal jaundice. Clinically, jaundice in neonates are when the bilirubin level is more than or equal to 5 mg per dl. Now, jaundice is classified into two: physiological jaundice and pathological jaundice. In physiological jaundice, jaundice never appears in first 24 hours, but in pathological jaundice, it appears in first 24 hours of the life. Now, in physiological jaundice, always unconjugated bilirubin is present, so urine does not stain diaper or no pale stool is present. But in pathological, conjugated or unconjugated bilirubins are affected, so high color urine and pale stools may be seen. And in physiological jaundice, icterus does not involve palms and soles, but in pathological, palms and soles may be stained yellow. And in physiological, clinical jaundice does not persist beyond 3 weeks, but in pathological, it may persist for longer. Now, breastfeeding in jaundice decreases the rate of jaundice. So, increase the breastfeeding will directly decrease the rate of jaundice in the babies. Now, there's one entity also known as breast milk jaundice. This is due to inhibitors present in the breast milk like pregnenolone or FFA that inhibit conjugation of bilirubin. So, breast milk increases the enterohepatic circulation. Now, treatment is continue breastfeed unless bilirubin level is more than 20 mg per dl. Now, moving on to the causes of neonatal jaundice within first 24 hours of life, that is the pathological jaundice. Most common causes erythroblastosis fetalis. Now, here two type in hyperbilirubinemia is seen in two type like unconjugated and conjugated hyperbilirubinemia. In unconjugated, increased production is seen like in erythroblastosis fetalis, hereditary spherocytosis, and G6PD deficiency. Also, decreased coagulation is noted in Crigler-Najjar syndrome. Now, in conjugated hyperbilirubinemia, two causes are there: due to non-obstruction of the pathway and due to obstruction of the pathways. Non-obstruction pathways include like infections, metabolic disorders like alpha-2 antitrypsin deficiency, galactosemia, tyrosinemia, cystic fibrosis, or idiopathic neonatal hepatitis. Most common cause of conjugated hyperbilirubinemia in neonate is idiopathic. Now, in obstructive causes, obstruction is in the pathway of the bile metabolism. Now, it is bile, so it is further divided into the intrahepatic and extrahepatic. So, in intrahepatic, congenital hepatofibrosis, Caroli's disease, Alagille syndrome, Durbin-Johnson syndrome, and Rotor syndrome. But in extrahepatic, like biliary atresia, Kansai procedure, or most common indication of liver transplantation in children is biliary atresia. Now, for assessing the level of bilirubin in the body, we use the modified Kramer's rule for estimation of bilirubin in children, which depicts that face encloses the 4 to 6 mg per dl, chest and upper thorax includes 8 to 10 mg per dl, and lower abdomen and thighs 12 to 14 mg per dl. Arms and legs include 15 to 80 mg per dl, and when the palms and soles are involved, that means bilirubin level is more than 20 mg per dl or equal to 20 mg per dl. Kernicterus is CNS manifestation of hyperbilirubinemia. In this part of brain, which is most common involved is basal ganglia, and type of cerebral palsy is extrapyramidal or dyskinetic type. So, acute bilirubin encephalopathy. This causes hypotonia, poor feeding, opisthotonus, seizures, and may also lead to death. So now moving on to the treatment part. First we will do the investigation. Investigation is done by the serum bilirubin levels. So after assessing the serum bilirubin level, we will move on to the management part, which are like phototherapy is given for most of the jaundice patient. And if the baby is developing jaundice more than 18 to 20 mg per dl, then exchange transfusion is done, usually done in RH incompatibility fetuses or baby. Phototherapy is the most effective method for the jaundice, in which wavelength used is 450 to 460 nanometer, and most important mechanism behind the phototherapy is structural isomerization. And factors affecting the effectiveness of phototherapy are exposed surface area of the baby, type of lamp LED, what type of LED is used, distance between the baby and the phototherapy, and it does not upon the skin pigmentation. Adverse effect of phototherapy are bronze baby syndrome in case of conjugated hyperbilirubinemia, and water diarrhea is also seen as an adverse effect, dehydration, hypocalcemia, retinal toxicity, and gonadal toxicity. Mean normal HB of neonate is 16.5 gram per dl. Indication of exchange transfusion in RH incompatibility when cord blood bilirubin level is more than 5 mg per dl or cord blood HB is less than 10 gram per dl. Also, for exchange transfusion, cutoff levels are there. When the age is 24 to 48 hours and bilirubin level is more than 50 mg per dl, then phototherapy is given, and when there more than 20, exchange transfusion. When the age is 48 to 72 hours, if bilirubin level is more than 18, phototherapy is given, and more than 25 mg, then exchange transfusion is given. When more than 3 days or 72 hours, then if bilirubin level is more than 20, phototherapy is given, and when it is more than 25, exchange transfusion is done. We can simply remember it by the method like when the bilirubin level is more than 20 or 22 mg per dl, we will mostly opt for the exchange transfusion, and when the bilirubin level is more than 8, then phototherapy is used irrespective of gestation age.